Welcome everybody. Today's presentation is APRICOT trial comparing two-layer compression bandaging for chronic venous insufficiency. This is a Milliken Healthcare sponsored presentation. To begin, we would like to give an overview on who we are as a company. Milliken Healthcare is a division of Milliken & Company, a family-owned U.S.-based organization in business for more than 155 years. The first dressings were commercialized in 2007, combining the innovation of Milliken & Company's textile and chemical technologies. In June 2019, a leading U.S. manufacturer of cohesive bandages and compression kits, Andover Healthcare Incorporated, was acquired. Other divisions within Milliken include chemicals, floor covering, and textiles, in which products that you all are familiar with incorporate their technology. Some examples include nonwovens found in wipes, masks, and surgical gowns, wovens found in uniforms, bandages, and wound dressings, and knits found in compression bandages and hosiery. At Milliken Healthcare, we aim to improve patient lives together by providing the following but not limited to product offerings: Coflex TLC compression kits, Coflex cohesives, Tritech and Ultra wound care dressings, and Assist burn care dressings. Today's presentation of the APRICOT study incorporates the use of the Coflex TLC Calamine compression kit. I'd now like to turn the presentation over to Dr. Leon Jonker, where he will dive deeper into this published APRICOT comparison study.
Hello, my name is Dr. Leon Jonker. I'm the Science and Innovation Manager at North Cumbria Integrated Care NHS Trust, which is part of the National Health Service in England. Together with a general practitioner and a vascular specialist nurse, we devised, conducted, and analyzed and published the APRICOT trial. It's published actually in the British Journal of Community Nursing in a supplement for community wound care. Obviously, the full paper can be obtained and read at people's own leisure. So the APRICOT trial was made feasible through a non-restricted grant by Andover Healthcare, which is now Milliken Healthcare, who produce and manufacture and market the AndoFlex TLC Calamine. So the product which I've got here is obviously the initial layer, you can see, which is the Calamine impregnated skin touching layer, and followed by the second top layer, which is the stretch and compression with the circular indicators, which are elliptical when it's on the roll, and then when stretched appropriately, it's a circle. So that's the product. So we feel it's important to conduct studies for wound care product beyond a case study or case report or case series, and hence we came up with APRICOT, which actually stands for a patient and clinician reported impression of compression therapy. Now, the study obtained full ethics approval and governance approval. Patients were given information leaflet, ample time to consider the study and ask questions, and then also provided written informed consent before they participated. So before talking you through the results, I'll first sort of reiterate why it's important to look at the effectiveness of wound care products. So wounds lead to very high morbidity and mortality, and the costs associated with wounds are immense. Wound patients in the National Health Service in the UK, for example, cost £5 billion more per annum to look after when compared to matched non-wound patients. Patient compliance is important, and previously in the literature it's been published that certain symptoms or incidences can lead to less compliance, such as itchiness, bandage slippage, a feeling of heat, and constriction or movement restriction. So that obviously sets the scene for doing a more in-depth study on AndoFlex TLC Calamine. Before moving on, because obviously I'm using the word AndoFlex, it's worth bearing in mind that in the rest of the world, the product is actually called Coflex TLC Calamine. And for reference, this slide also shows obviously the different boxes with full compression and light compression on the left and the right hand side, and then the respective Coban 2 products, which are also full compression and light compression. So the APRICOT trial was set up, and we assessed 61 patients for eligibility, 22 were excluded. Some reasons for exclusion were, for example, end of life, the lack of capacity to consent to taking part. That left us with 39 patients who provided informed consent. It's important at this stage to mention this was very much a pragmatic trial, so therefore patients were allowed to enter the trial if they were already on compression bandaging, if they were new patients. They were also allowed to be given either full compression or light compression, depending on the clinician's opinion, which was guided very much by the ankle brachial pressure index and other medication or wound care of the NOLs on the patient were not affected by this trial. So patients were then randomized. So by chance, they were given either Coban 2 first for 3 weeks or AndoFlex TLC Calamine for 3 weeks before they were then crossed over to the other bandage. So obviously each patient was given the chance to try both AndoFlex TLC Calamine and Coban 2. So that obviously gave us the opportunity to look at preference. So that's a good point about this crossover design. We did not include patients for those that we only had one outcome for. So for example, they only tried Coban 2 and not AndoFlex, or vice versa. One patient was withdrawn from wearing AndoFlex because the patient developed a mild rash on the index leg, and the clinician in question removed the AndoFlex and withdrew the patient. Now, we did not perform a re-exposure experiment, so therefore we can't be certain if it was actually the AndoFlex TLC Calamine that caused that rash. It could have been for a different reason or flare-up related to that chronic venous insufficiency. But that was one patient that was lost there. Whereas for Coban 2, we also actually had a patient who wanted to withdraw from having the Coban 2 because they felt that the compression bandage was intolerable. So it's a 1-1 there. Other than that, all the other patients were happy enough to continue wearing both sets of compression bandage. It is worth noting that for one particular patient, the compression bandage had to be changed every 2 days for Coban 2 because they then felt it became too uncomfortable to wear. Whereas once they wore AndoFlex TLC Calamine, they didn't need it changing until the indicated 7 days. So there was a longer period that they could tolerate AndoFlex over Coban 2. So in the end, we managed to analyze approximately 35 patients for the different outcome measures. So in terms of the outcome measures, we first looked at symptoms that have been published before in the literature, and also we included coldness because we anticipated that Calamine would have a degree of soothing, which is it's designed to do in other conditions. So from left to right, we've got coldness, itching, constriction, bandage slippage, movement restriction, and pain. And this graph is for the incidence of the symptoms, not the severity, which I'll come on to next. So we can see from this that itching pruritus is the most common symptom, and that sort of validated or justified us using a few more outcome measures for itching as well, which again I'll explain in the next few slides. Other symptoms were not really that common at all, such as bandage slippage or movement restriction. They weren't seen as an issue by hardly any patients. In terms of coldness, this is actually something that came up in a free text option for patients to give feedback on each compression bandage. And for AndoFlex TLC Calamine, about 6 or 7 patients mentioned that the bandage was soothing or cooling. So in terms of severity, again, let's home in on itching because that's the the most sort of bothersome symptom for the participants, for both the AndoFlex and the Coban-2. Although there seems to be a trend, patients who are affected by itching, which is less than 50% of the visits. For AndoFlex, it tends to be a mild, patients seem to be mildly affected, whereas for Coban-2, there's more of a distribution from being mildly affected, moderately affected, or severely affected. So as mentioned, we had some other outcome measures, again, to be recorded by the patients themselves. So patient-reported outcome measures, PROMs. And one was the SPS, Severity of Pruritus Scale, which looked at the last 24 hours and then asked the questions and answers on a Likert or ordinal scale. Whereas the bottom one was the Pruritus Visual Analog Scale, which was one question asking about the last 2 weeks in terms of itching. And patients were asked to draw a vertical line on a 10 centimeter ruler with some smiley and less smiley faces to guide them. So we actually see the outcome measures for this, which is table 2 from the original paper. We can see that severity of pruritus score, which is the top row, and visual pruritus scale, which is the middle row, both saw a similar treatment effect, which is the p-value figure right on the right-hand side when we looked at the crossover analysis. So it's a p-value of 0.2 roughly. A trend towards AndoFlex DLC Calamine showing less itching. The 5D itch score at the bottom was a slightly longer questionnaire for patients, again, around itching, and showed similar outcomes. One potential downside of doing a crossover design is that you can have a carryover effect, which is the second to last column on the right-hand side. The carryover effect is effectively when an initial intervention that you do, in this case, obviously the first 3 weeks of a compression bandage, may still exert an effect into the second 3 weeks of the next intervention that you apply. In our instance, we did not see a significant carryover effect, which is good to see. We could not really do the gold standard, which is to have a washout period of no intervention, because these patients, they need compression bandaging. We did go a little bit further and also ask clinicians to report some outcomes. One was the push score, which is a semi-quantitative measure of a wound size. Now, the vast majority of patients did have a wound, so therefore it could be used. And we did see a significant treatment effect, as you can see on the right-hand side. So the AndoFlex seems to promote healing significantly more than Coban-2. This is mirrored with the VCSS, which is the Venous Clinical Severity Score. And again, we saw a significant effect for AndoFlex DLC Calamine. And the Venous Clinical Severity Score looks at things like the ulcer size, but also degree of inflammation and other clinical parameters. The bottom one, Civic 20, is yet again a patient-reported outcome measure, and it's a questionnaire looking at quality of life related to someone's chronic venous insufficiency. And again, we saw a promising result there for AndoFlex, but not statistically significant. Now, it's worth bearing in mind, obviously, that as I mentioned earlier, we had a combination of patients who did have an ulcer, did not have an ulcer, and also patients on light compression and full compression. So there was a bit of a mixed bag of patients. So a purer sample would have to be used to really double check that these effects are reproducible. Now, lastly, after patients had tried both sets of compression bandaging, we will also be in a situation where we could ask them what their preference was. When we look at questions, one patient's preferred overall, and the dark blue is that they definitely preferred AndoFlex DLC Calamine, and that was the case in 60% of patients. Whereas approximately 10% of patients definitely preferred Coban-2. And the reason seems to be that AndoFlex DLC is more comfortable for the skin for the majority of patients. When it comes to sort of movement and practicalities of the compression bandage, which is more questions 4, 5, and 6, we can see that the was really not much of a preference in terms of which compression bandage is better for wearing with shoes or to move about in. This gives us an overview, obviously, of what symptoms are the most common when people wear compression bandaging in this patient population in the UK, and pruritus is deemed the most bothersome symptom reported for both compression bandage brands, so both for AndoFlex DLC and for Calamine 2. So it's useful to establish that, and that can be something that clinical staff can perhaps focus on when appraising compression bandaging with patients. Now, trial participants also noted soothing and cooling, as I mentioned, and this was exclusively for AndoFlex DLC Calamine. And as we saw in the last slide, 60% of participants preferred AndoFlex DLC Calamine. And 5 nurses who were involved in looking after the patients whilst they were in the trial, and obviously applied both AndoFlex and Calamine 2 through that period. Those 5 nurses were asked as well about their preference, and all 5 nurses, 100%, did prefer AndoFlex DLC Calamine over Calamine 2. So this was an overview of the APRICOT trial and the setup and the results, and then the discussion of the outcomes. So obviously this gives sort of a baseline and a good starting point for the comfort, efficacy, safety, and effectiveness of different compression bandages for patients with chronic venous insufficiency. So I hope you enjoyed watching this webinar, and I would like to thank you for your attention.
Thank you, Dr. Jonker. Now we will hear more about the Coflex TLC Calamine compression.
Milliken's Coflex TLC 2-layer compression kits are designed to enhance the experience of both the clinician and the patient. Clinicians can choose from a wide variety of options to best solve their patient's needs. All Coflex TLC products promote safety through consistent application across the entire product line, feature easy tear technology for convenience, and include visual indicators to guide intended compression. Coflex TLC Zinc or Calamine standard and light compression kits include 2 rolls and an extra large nylon stocking. These moist compression bandages are designed to replace the mess and unmeasured compression of a traditional Unibu. Layer 1 is an impregnated foam with up to 50% more zinc or zinc calamine than a traditional Unibu, and can hold up to 20 times its original weight. The soothing calamine and zinc can be used on dry or scattered skin irritations and can conform to difficult to wrap shapes. Layer 2 is a moisture-resistant, controlled compression, cohesive layer that includes easy tear technology and visual indicators to help provide restorative compression. In preparation for the application of the Coflex TLC Calamine kit, dress the wound with an appropriate primary dressing. To begin wrapping, dorsiflex the foot or toes to the nose. When applying layer 1, start at the top of the foot at the base of the 5th digit or pinky toe. Continue along the base of the digits, angling while spiral wrapping around the foot. Now for the second step of layer 1. Proceed to the ankle and make 1 figure 8. Starting by going around the back of the ankle, continuing under the foot, stay close to the heel. Avoid going directly over the heel to prevent pressure injuries from possible folds in the foam. At this point, there may be a slight gap in the heel region. In the final step of layer 1, continue up the leg in a spiral fashion overlapping 50%. A correct 50% overlap can be indicated by a uniform shade of color. End the spiral wrap a 2-finger length under the bend of the knee for optimal comfort. Cut or hand tear layer 1 to begin wrapping layer 2. Dorsiflex the foot or toes to the nose. When applying, start the cohesive in full stretch on the top of the foot at the base of the 5th digit or pinky toe. Continue along the base of the digits, angling while spiral wrapping around the foot. Now for the second step of layer 2. Proceed to the ankle and make 2 figure 8s. Start the first figure 8 by going around the back of the ankle, continuing under the foot, staying close to the heel. For the second figure 8, follow the same path around the ankle as before, then continue directly over the heel to enclose any gaps. Hold the cohesive roll by the core with one hand. Use the other free hand to guide and smooth out any wrinkles. Continue up the leg in a spiral fashion with a 50% overlap, pulling the cohesive out 6 to 8 inches before guiding it into place with the free hand and keeping an eye on the indicators. The consistent shape of the indicators will help provide restorative compression. As you approach the final spiral wrap, confirm that the temporarily secured layer 1 is untucked. Completing the spiral wrap 2 finger lengths behind the bend of the knee for optimal comfort, ensure that cohesive ends on cohesive, and finally, cut or hand tear. Rub the end of the cohesive for a tight seal and hug the leg all the way down. To assure patient comfort and that the wrap is not too tight, confirm 1 finger space near the toes and knee. Included in every box is an extra large stocking that can be worn over the completed application of layer 1 and 2. When applying, pull the stocking seam away from the toes to help prevent irritation. This stocking will not increase compression and allows for ease of movement in everyday life.